name is B. Rej. I'm a breast imager at NYU Langone Health, and I'll be presenting a case of breast pseudoaneurysm. The history is of a 49-year-old woman found to have architectural distortion on screening mammography with associated irregular mass with distortion on ultrasound. She had a history of deep venous thrombosis and was taking rivaroxaban, which was discontinued 4 days before biopsy. Ultrasound-guided core biopsy was attempted, but stopped after one pass due to bleeding. The core biopsy result was benign and considered discordant. When the patient presented 5 weeks later for a second attempt at biopsy, a pseudoaneurysm was identified at the biopsy site. Transverse and longitudinal grayscale ultrasound images demonstrate an irregular spiculated mass, denoted by white arrows, with posterior acoustic shadowing, denoted by the yellow arrow, and architectural distortion, denoted by arrowheads, in the right breast. Transverse grayscale ultrasound image of the right breast during an ultrasonic-guided biopsy of the mass, denoted by the white arrow, with a 12-gauge vacuum-assisted needle, shows the needle in the pre-fire position, denoted by the yellow arrow. Post-fire images were not obtained due to bleeding. Ultrasound performed 5 weeks after biopsy. Transverse and longitudinal grayscale ultrasound images demonstrate an oval, circumscribed, mixed echogenicity mass, denoted by green arrows, adjacent to the site of biopsy. On color Doppler, there is flow within the mass that enters through the aneurysm neck, denoted by the white arrow, then swirls within the aneurysm sac, creating the yin-yang sign, denoted by the yellow arrows. The feeding artery is identified contiguous with the lesion, denoted by the red arrows. Ultrasound-guided compression of the pseudoaneurysm was attempted, with no change in size of the pseudoaneurysm. Repeat biopsy of the shadowing mass yielded benign results, deemed discordant, and excision was recommended. 1 month later, when the patient presented for ultrasound-guided localization prior to excision, a transverse grayscale ultrasound image of the right breast demonstrates a persistent cystic mass, denoted by the arrow, that has not changed in size. The pseudoaneurysm was excised along with the area of distortion, which yielded radial scar. The final diagnosis is pseudoaneurysm due to core needle biopsy. The imaging findings are: grayscale images show a cystic mass at the biopsy site. Color Doppler shows swirling flow within the cystic structure, yielding a yin-yang appearance. The feeding artery is contiguous with the lesion. The top differential diagnosis is of a cystic mass. All breast masses should be evaluated with color or power Doppler ultrasound. A mass that appears cystic on grayscale ultrasound but has internal vascular flow is most likely a solid mass. Alternatively, if there is marked flow with a swirling internal appearance, then this suggests a pseudoaneurysm. Take-home messages. 1. A pseudoaneurysm is due to a defect through all layers of the arterial wall with development of a blood collection that is contained within a sac lined by the external connective tissue of the vessel wall or the surrounding soft tissues. 2. Pseudoaneurysms in the breast are iatrogenic, forming as a rare complication of core needle biopsy, either ultrasound, stereotactic, or MRI guided. 3. Pseudoaneurysms may be immediately identified after biopsy when excessive bleeding is noted at the biopsy site, or the diagnosis may be made weeks after biopsy. They may be found incidentally after biopsy or may present with symptoms. 4. In the breast, all sonographic masses should be evaluated with color or power Doppler ultrasound. 5. Treatment options for breast pseudoaneurysms include observation, compression, which may be guided by ultrasound imaging to ensure focused compression on the pseudoaneurysm, thrombin or alcohol injection under ultrasound guidance, percutaneous embolization, and surgical repair. Thank you very much for your attention.